This is Kenya's biggest conversation, and now we are in the second hour of the show this lovely morning. It's the 21st day of December 2021. Happy Tuesday, wherever you're tuned in, whether you are on SpiceFM or streaming the show online, SpiceFM KE, YouTube, Facebook, or Twitter. City Muga has two proverbs. It's Christmas after all.
Well, we're heading in that direction.
Yeah.
Chanda chema huvikwa pete.
Chanda chema huvikwa pete.
Yeah, directly translated, the handsome finger gets the ring.
Mm-hmm.
That is, of course, if you want to animate the finger and make it handsome. Mm-hmm. Then, the second proverb, mkia wa nyani haubanduki nyani.
Mkia wa nyani haubanduki
Yes.
nyani. In English?
Well, the tail of the monkey never really leaves the monkey.
Let's chop it off.
See monkey, see tail.
Monkey never loses its tail.
See tail,
See monkey.
See corruption, see politician.
Oh, goodness.
Parliament of monkeys.
You really think that pluralism was for nothing?
Let's discuss universal health coverage. And joining us in the studio this morning is Dr. Rispah Walumbe. She's a health policy advisor with Amref Health Africa. Dr. Walumbe, good morning.
Good morning. Thank you.
Good to have you in this situation, bro.
Thank you for having me.
Happy holidays.
Happy holidays, although it doesn't quite look quite like Christmas like we're used to, is it? Yeah.
This December is not December-ing.
It's not December.
Like the way December is usually December.
Yes.
Welcome to the hot seat. We call that the hot seat. We just warm it up for our guests so that we can have a nice, comfortable conversation. And this one is about universal health coverage, which we have had a number of times. Universal health coverage from government, from the policy, from various angles. Now, let's look at it, universal health coverage in Africa. So recently, there was a conference called what?
The inaugural conference on public health in Africa. So it was the first of its kind.
Okay.
Yeah.
What was that all about?
So I think one of the things that was going on is that for a long time we'd been planning to have a conference in, of that kind in Africa, hosted by Africa and for African public health experts, but also for government and for different actors. So the Conference of Public Health in Africa was really looking at the COVID-19 situation on the continent and trying to figure out how exactly we can kind of create our own solutions and actually scale the things that we had been discussing for a very long time over the past 1.5, probably 2 years around COVID. And then, of course, aligning that with kind of like the health system challenges that have been persisting in the continent.
Okay. What's the status of our health in Africa?
I tend to be quite optimistic generally. But I think in terms of the state of health in Africa generally, each country is at different points, right? Just because they're very unique contexts, and generally Africa is very diverse. But in terms of just, putting a pulse on it or having a temperature check, I think now more than ever, there are more investments going into healthcare, healthcare systems in Africa, just because of what we've seen over the past, 1.5 years. But also before that, there were already discussions around how do we make more investments in our healthcare systems so that we're able to kind of liberate ourselves from external funding and make sure that we are looking forward, looking towards the future. Yeah.
Even as you say this, I'm just checking on some things here. Are we looking then, being optimistic about the state of health and then universal coverage and, care in countries on the continent? Is this government-led and government-funded, or is it government with an initiative that then brings in development partners?
So when you look at the African context and even you look at the African Union, right? Different African countries have gone through a very long history when it comes to universal health coverage. And even if you look at the evolution of healthcare policy in Africa has actually been situated, first of all, by Africans as a right. Right. So this was even prior in the immediate post-colonial period. We had said that healthcare is a right for us, right? And then, things happened and there were external influences that kind of shifted that goalpost and made sure that we we kind of not focus too much on that. But in terms of whether this is government-led, just in the same spirit of the post-colonial period, right now it is still government-led. And in terms of the funding, it's a mixed bag, right?
Okay.
Again, going back to the thing that different countries are at different levels. So you have low-income countries, you have lower middle-income countries and low-income countries. But generally, the move or the conversation is around sustainable domestic financing.
Okay.
Yeah.
Can I tweak that question a little bit?
Yeah.
All right. So, are governments able, the way in which this care is envisioned in the minds of practitioners and experts, and looking at the plan, are governments able to initiate and sustain this plan with what we currently have?
In the current situation, I would say that no, that's the short answer. But in terms of the fact that people have started to look at, it's not just about increasing the money, it's about doing well with the money you have. So that means increasing efficiencies. It's looking at making sure that we're using it more effectively. And it's also looking at where we can direct our investments, right? Because even healthcare, as much as, we look at economy and look at infrastructure as things that we look to invest in because they have a good return, healthcare is just the same, right? Because you're looking at it not just in terms of something that we look at as a public good, as something that is a human right. We're actually also looking at it as an investment. And I think COVID-19 has shown us, how the impact of healthcare, if you don't look at people's healthcare and make sure that health systems are strong enough to cope with that, then those investments, kind of fall by the wayside. So in terms of whether countries can, I think they definitely can, because but it's something that all other countries, if you look at even high-income countries, middle-income countries, particularly look at the Asian giants and those people who have a good healthcare system, as we call it, quote unquote, it took time, right? Sure. But it started with small investments, starting off with things like primary healthcare. So looking at that.
The story of universal healthcare has a very nice ring to it. It's a pleasant ring, and if one were to be hopeful, it's one of the things that one would sort of want to invest all their hopes in, because it provides something that nothing else can in the way that it does. And often the discussion is about, is the government able? I find that discussion is misplaced. I would rather ask the question, is the government willing?
That's a hard-hitting question. So part of my role is, where I work is to mix it between collaborating with different actors, both state and non-state actors. And for the experience that I've had in terms of collaborating with state actors, there's definitely the will. If you look at the context here, there's definitely the will to do so. It's just that we have an institution. We have different institutions with different things that you have to engage in, different people you have to engage in, because remember, when we say government is a big animal, right? There's so many different actors within government, and it's about also making sure that people understand the concept of universal health coverage and understanding that, for instance, one country A's universal health coverage picture or journey does not look like country B's. So that means you're trying to also understand people's mindsets and figure that out, and then also contextualize all that you've heard about UHC into what that means for your country. So that's a challenge that governments often experience. And but I would say that in terms of the willingness, from what I have experienced and from the discourse that I have been part of, it's something that you've definitely seen. It's just a mixture of how do you actualize all these dreams, right? Which is very difficult, especially when you look at, in some countries, the fiscal space is actually reducing. And to deliver on this big dream as the dream we're seeing in 20, 30 years, to start off by thinking of that, dream, that big investment that you'd need to make, or the amount of money you'd have to make that happen is something difficult, just by the situation, by virtue of where we are.
Yeah. I'm a bit frustrated. I mean, coupled with your optimism, Doc. But I look at health and coverage on the continent, and I look at all these other competing factors. And unfortunately, health is an extremely dependent sector, that is dependent on so many other things in order for it to work superfluously. As in, there is so much that is needed. You must have infrastructure that is in place, water running, electricity uninterrupted, proper infrastructure in terms of the mechanics that you need, facilities, proper resource in terms of human resource. And then I look at some of these factors, and they are the debilitating factors that are currently existing in a lot of the countries on the continent. And health is dependent on all of these things. How then will we say that things are looking up if, unfortunately, we can pinpoint some of these things as stifling issues?
So actually, I would put that two ways, right? So the health is not only, as you say, it's dependent, but I think it's also an anchor for all those things to actually function, right? So when you're looking at, I'll give the example of, again, going back to COVID-19 and looking at how countries, first of all, started their focus or arranged themselves to kind of tackle this big giant, right? First, they did one of the things that I think was one of the things we looked at recommending as something that people need to continue with is multi-sectoral collaboration. So understanding that I look at health as an anchor. Health is actually, one, it's kind of like the canary in the coal mine. It first of all it gives you the pulse of what's going on in your country, but it also gives you an understanding of kind of like the layout of the landscape. So during COVID-19, especially in the initial throes of the pandemic, there was a lot of multi-sectoral action with health as a guide. So if you look at ministries, Ministry of Health in many countries was kind of the spearheader, like the leader, and people took lead from the Ministry of Health. And where you saw, whether it was when we're looking at food security, whether you're looking at infrastructure, making sure some of these things were put in place, the speed at which governments were able to act was something that we hadn't seen. Like in my lifetime, I hadn't seen it. And I think those are some of the things that we need to build on, because we actually did really well, especially given the circumstances that we were in, fighting an enemy we did not know, did not understand, and did not see. So I think those are the kind of things that we need to build on. And for me, that's why I remain optimistic, because we have shown that we are able to use that to do it and to work collaboratively. And so if we're able to use that and even use health, again, as the canary in the coal mine, as our indicator for whether all these other sectors are collaborating, are working well, then I think that's the kind of the focus that we should kind of take.
You talked about each country having its own picture of what UHC is all about. Yeah. You launched a report during this conference called what?
So it
UHC
was
in Africa.
Yes, so it was basically the State of UHC in Africa, and it was a report that was launched by the High Commission. So we usually have the Africa Health Agenda International Conference, which is a 2-year conference. It happens every 2 years. And in 2019, one of the things we did was we launched a commission, or there was a call for a commission that would be Africa-led, that would look into Africa, look into the healthcare context in Africa, and kind of develop a report that would give us the perspective on what exactly is going on in Africa when it comes to universal health coverage. There are many reports, of course, that do this. It's just that we wanted to make sure that this was something that we could do differently. And I think one of the things we tried to do with this, and I think we successfully did, was it's not just giving numbers. It's not just saying X% was able to, in terms of the traditional indicators, we went a little bit further because we wanted to contextualize the challenges that many countries are having. But then we looked at the challenges, both historical, we looked at, the current health system, broader contextual challenges. So the things you're talking about, the system as a whole, supply side, demand side. And then we also went on to say, actually, Africa is ripe with opportunities, right? So there are actually opportunities we can leverage. And that's what we identified in the report. And then thereafter, what we did is we also provided recommendations for different actors. Because as much as UHC is, again, government-led, it's government spearheaded, we look at it as everyone's business, right? We look at it as everyone's job to make sure that we succeed in this journey. So that means we looked at recommendations for state actors and recommendations for non-state actors. But then something also unique we did with this report is that we didn't want to just, it to be professionals who are just sitting down and writing a report. We went out and actually sought for community stories. So we wanted to contextualize those numbers. We wanted to say, if someone is saying that, service coverage is difficult for them, they're not able to access services. We looked at an example. We looked at people who submitted stories and said that actually, yes, this is true, or this is not true in my context, or this is what the major challenge is in my context, and this is what I can do to make sure that, I'm able to access services, or just kind of like making sure that this is something that's tangible, that's visible for people, and everyone can understand and consume this report in that way.
So from all that research and study that was done,
Yeah.
how diverse is the UHC picture in terms of the way governments have conceptualized in Africa?
So
are we talking about the same thing when you say UHC in Kenya versus UHC in Senegal, UHC in the Gambia? Is it the same thing we're talking about?
So when you're looking at the design of universal health coverage in different countries, let me start with the fact that generally, I think it's about 50 out of the 54 countries that we found. So that's about 93% of countries actually have a statement on universal health coverage. So there's actually a political commitment, or there's a universal health coverage policy document, or there's some guidance in terms of a framework that the country is operating on that is guiding them towards UHC. And that means that they have, looked at the UHC tenets, which are 3, which is looking at equitable access to care. It's looking at quality of that care, and it's also looking at financial protection. So that means you're not falling into poverty as a result of trying to seek that care. So the way countries will design that is very different. So that means that, for instance, if a country decides to look at how they will ensure financial protection, that could be through ensuring that they collect enough funds to be able to include that in an insurance package, right? And that means that it can be a prepaid mechanism to make sure that people do not have to pay at the point of care, because often that payment at the point of care is what diverts people from healthcare.
Yes.
And they often come too late, right? So a country might decide to go through the, exclusive tax route, where you pay directly to healthcare facilities as a government, and then you have people just access that directly. And then you could also have a situation where a country will say, we want to have a social insurer who will deliver on that, and we will pay that social insurer, and that social insurer will then pay providers. So that's an example of one tenet, right? So different countries, but we measure them based off of those 3 tenets: financial protection, service coverage, and
Equitable access.
equitable access, and the quality of that care.
Okay, so then even as you were putting this report together, and as you see the achievement, so obviously from what you've said and from what we understand, that achieving UHC, complete coverage, is the end goal. And there are certain things that certain countries have already done and put in place. What are the recommendations then you're saying that need to happen to move this along?
Okay. So when you look at the recommendations, I'll put them into kind of like 2 aspects, right? So you have recommendations for state actors, right? So you have recommendations for different government arms. So that could be legislators, that could be, the policymakers, the people who sit in ministries of health. And then you also have that for implementers, the people who are actually the doers at the community level. And each of those recommendations are broken down depending on, kind of like the policy guidance that the country has. But when you're looking at the specific recommendations, the first one we're looking at is looking at making sure that we continue the investments we made during COVID-19 to kind of like see what has worked, what actually worked, and how do we sustain those things. Another recommendation is for government is looking at how do you make sure that you invest in primary health care, right? Because primary health care is, the start, because ideally that's the first point of care. You want to make sure that people have access to care. They're able to see, even when they're well, they should actually be able to still go to a healthcare facility, right, to maintain their health. So looking at it in a more holistic approach, looking at it from communities, what do communities need? then that also then shifts that also goes to another recommendation, which is really rethinking how we've designed our healthcare systems. What actually works for your country? What works for your community? What does your community want? So that means that governments will be responsible for looking at what exactly in your health system, based off of the design that may have been influenced, again, by looking at our historical past and looking at the colonial influences, what do we need to then shift back towards what actually communities want? So part of that is looking at, how we engage with community health workers, and then looking at how as government, you want to make sure that you're working in that collaborative nature that I had described. Right. Then now when you look at non-state actors are so diverse, right? So you have private sector where you have the for-profit versus not for-profit sector, and then you also have civil society. So when you're looking at all of these different actors, all of these different institutions that work alongside the state, because remember we said that it's both state and non-state actors are responsible for kind of like spearing this forward. You want to make sure that, for instance, private sector are looking at how do we make sure that we have better commodity security, for instance. So that means that how do we make sure that if we're able to, we manufacture things locally, we're able to reduce the prices, we're able to defragment the healthcare market, because we've been able to we're actually in conversation right now, and I think this is one of the sideline conversations at the conference, was to ask about how can we make sure that we're able to purchase things at a cheaper price, right? Especially for the healthcare market. Because if I'm having to buy pharmaceuticals from external, people external from Africa, and I'm buying them at a higher price, yet I can manufacture them locally, how do I make sure that I do so? Because that, again, infuses more money into the economy. It makes sure that I'm not paying like extremely high, exorbitant prices, and I'm able to make sure that I'm secure, like in terms of commodities.
Right.
Yeah.
Dr. Rispah Walumbe is a very optimistic health policy advisor from Amref Health Africa, and she's telling us about universal health coverage in the continent.
There is this little detail about the continent, the population of its youth, the significance of that number, and the question has to be asked, when you're talking about UHC, do the youth have a role to play in the realization of this? Do their numbers influence the thinking and the policies behind the implementation of the UHC program? And in the conference that you had, in the findings that you came up with, what were the considerations that were made and recommendations thereafter with regards to the youth?
So in terms of what, the youth can do, I feel like one of the things that I feel like they should be involved at all levels, right? From the aspects of policy making to implementation of universal health coverage, all the way down to even monitoring it, right? And being that accountability partner for the government. So when you look at different things that the young people can do or youth can do, in terms of being involved in healthcare policy, that's something that is there are very many examples of how young people have been involved in healthcare policy. So for instance, in terms of, I think there's an example of even having like a youth parliament and looking at what happens in that context, and how they advise, actual legislation, how they're able to put a pulse on what exactly is going on when it comes to healthcare. But I think the first step is, one, knowing that actually UHC is for everyone, including them, and really just diving into the details, right? Because the devil is in the details, and that's where you can either be disenfranchised or be empowered. And part of that is making sure that you are in the conversation. You are not asking for a seat at the table. You are part of, all the seats. You are part of the table. You're part of the conversation. So that means that in terms of the recommendations that we made, it looks at making sure that people are consciously making sure that those people who are involved in this process it should include young people. It should have youth at the forefront in all levels, particularly at the youth policy, at the policy level, where they're able to not only influence policy, but also create it, craft it alongside government, or even be part of government in that context. But then on the other side, I would also say for those who don't want to engage in policy directly, they're able to look at the accountability aspect of it. And they can look at accountability, not just in terms of the legislation or the policy. They can also be involved in terms of even looking at how the healthcare system is structured. Does it meet their needs? Does it meet the needs of young people? Does it meet the needs of youth? Does it meet the needs of women and children and all these different things, right? And I think that's where, again, working collaboratively with the government and the government also creating spaces very deliberately where that is allowed, where that is not even allowed, but it's not even encouraged. I don't know. The word is to actually say it's a very deliberate thought. It's something that's actually put in legislation where you have to make sure that you have included that, right? And there are also those traditional methods where we have, for instance, in Kenya, where you have things like public participation, especially when it comes to bills being created at the county level. That's one of the things that I think, those are some of the ways that I think young people can get involved. And from my experience, especially when I would call myself not quite a youth, but when I was a young person, I was working together with, I know, you're laughing at me, but no, I think it's because by government standards, they say I've crossed the bracket. So I'm like, okay, fine.
Accept and move on.
So in terms of engaging in policy making, one of the things that I used to do was actually, sit alongside those conversations, be in those conversations, figure out what exactly is this animal called universal health coverage? What does healthcare for all really mean? And how can I be responsible for even crafting the papers that are taken to, those high-level meetings to be able to make sure that includes the needs that I have.
But is it from the other side? So if you're still on the youth agenda, and how the youth can then be involved in UHC and its policy, from the other side, is it open in terms of receiving this input or this participation by youth? Because it would seem as though those who are crafting policy, those who are establishing policy, institutionalizing this policy, seem to be in this cabal of experts and nobody can really crack it. It's got to be them and only them who understand what's going on. And any additional input is kind of like, okay, thank you very much, but then it's put in a box and forgotten about. And we're going to carry on with what we're doing. So is there acceptance of this input on the other side?
I don't think it's as good as it could be. Definitely not. We need to make sure that young people are put in that conversation and not just seen as tokenistic or just putting them there for the sake of it, for checking a box. It's to make sure that when they sit there, when somebody sits there in their authority, and I would even say some of these youth are the experts, right? You have those people who have the experience and they have that expertise in their own right, and they've established themselves in that capacity. And so I have seen instances where young people actually leading the charge, actually guiding some of the conversations when it comes to government direction. But I think it could definitely be done more because it has to be at scale. It can't just be the one or two people I see in a room. When I walk into a room where policy is being crafted, it can't be just those one or two people, and it can't also just be you have to have that high expertise. It should be that if you have a perspective, if you have a way that you see the healthcare system working that does not work for your community, as a community, if young people are even leaders of our communities, right? So how do we make sure that and I think that's a very strong recommendation is to the government, not even to young people. The strong recommendation we have to the government is create this framework where you are actually looking to us as the community, as the young people, as the women, whoever it may be, to have a situation where you can have that accountability framework, right? You can put them at the table, you can actually and listen, not just put them there and then not listen, right?
I understand the discussion around including the youth, but when we talk about expertise, are we saying the same thing? Because whenever we talk expertise, the leaning is towards academia. The paper qualification that somebody has had, the number of papers that they have been involved in writing, the number of conferences they have attended, the presentations they have made, further education that they have, that's expertise. And yet, when you talk about something like UHC, the expertise that is required is lived experience. Because that is what informs what is necessary, what is needed, because they know, because they live it. If you study and you bring these individuals as participants in your study, you are not an expert in their life. You are an expert in that specific aspect that you have studied. But the real expert in the community is always the community. Now, when we have these conversations, are we saying that those who are at this conference and those who sample-sized individuals, do they also have this understanding that when they talk to the communities, they're talking to experts?
Yeah, so thank you so much for that, because I one of the things that we have, one of the commissioners who not only looked at the colonial history that we had in the country, we had in Africa as a whole, but also looked at, the role of communities, because we've always looked at communities from, again, that colonial view that we are the experts and we are advising the community, or we are telling the community what to do. But really the shift that in the conversation is really seeing the community as the leader. They're the ones to tell you exactly what they need, one, because as you correctly said, they're experts in their life. They're experts in their experience. You cannot tell them what exactly they have done, what they should do. You work alongside them. You see how you can, fully make sure that they realize the situation that they need for their healthcare system. So part of what we did was looking at how we've talked, if you hear this in global health discourse, there's a lot of talk of people-centered healthcare systems. So making sure that you put people at the center and not look at it from the perspective of you're making this big healthcare system and you're trying to, make sure it fits into this context of whatever country you're working in. But we are looking at it from the reverse. How do you collect what exactly do people need, and how do you reorient? And that's the big shift we're talking about, reorienting it towards what they need and using their expertise, because I agree with you. That's their expertise as guidance, right? So definitely in terms of making sure that things are more people-centered, looking at communities as experts, that's something that we're trying to that we recommend very strongly in this report.
My question was, this partnership that you speak of delightfully eloquently, is it really understood and practiced?
So it's something that, is it practiced? I would say that it's a mixed bag. From what I've observed, just in my small observation. Why I'm saying that is because they're very, again, deliberate conversations that people are having around that, because people have observed that just the design of our health systems, the design of how we even engage in policy, it's based off of like those colonial hierarchies that were established, right? And we didn't look at it as we can actually shift that. And that's looking at that colonial narrative, it looks at it from a top-down approach. And that's why it's a very deliberate move that there are conversations around that people are trying to do a more bottom-up approach. Are they happening? In some cases, yes. There are examples that I have seen where communities are at the forefront in terms of sitting down and saying, no, this is not right. This is what we want.
Can you give us one of those examples?
So in terms of like when you're looking at, I think the example was in South Africa. And I think they also have a very strong, approach to making sure that you have a very deliberate community involvement. Where when even the design of research, for instance, right? So research is traditionally where someone comes from the external part and then they come and, they go and actually craft the entire research study outside of Africa.
Yep.
And then they come and do the research study and then they just ask the questions and, and then that paper, after they've had that conversation, they go and give that document to a policymaker and say, this is what should be done based off of the research that we have
conducted in your country.
But right now, if you look at even how we look at how academia is designed, again, it's a very rigid design in a sense. But I think one of the things that people are trying to do is really shift that, because communities, you should actually come back. It's actually, you're supposed to come back and actually tell them.
It's actually this is a requirement that must be in protocols.
Exactly.
That you must come back and tell them your
exactly
findings.
what you found. Yes. This is what you found. And is it
Does it represent the truth as you understand it? Yes.
Exactly. And so a lot that part is a big failing in terms of what has been happening on the continent. And now we're trying to say that how we even design this research should not be exclusively focusing on, as an expert, me who has gone to, in the I think they call them ivory or marble towers, to come and just design that and then come and tell you, like, this is what I want to ask.
That's interesting as you say that, because I listen to CT often and he talks about whom they used when they, in the field of research and HIV. And you'll find that the people that will be able to give you this expert advice are the people that we would often take for granted or forget about. That people who suffer a disease, people whose families have been ravaged by the illness, would be able to give a better understanding of then what you ought to do.
Those are the real experts.
They are the experts.
And you don't even attribute the information you've gotten to them.
So here we are calling, the folks who, inhabit these ivory tower, as you say, then come back here and then want to apply some knowledge which doesn't take into consideration the actual meat of the matter. So is it possible then, from what you've said and what you've observed, to flip the script when we look at UHC across the continent, that it's the people who know, for example, where the pockets of certain diseases lie, for example. They know who suffers what when. They know what they've been doing with young children who suffer things like dysentery and things like that. They have an understanding. How about involving, beyond the experts and beyond the external influence, to the actual people who have a feel of it? To me, you would be able to have a waterproof policy then that you can now apply, and maybe even have almost like kind of a turnkey policy that then works, because you've involved a real situation, not some amorphous thing that oftentimes we don't understand.
But you don't do, even as we say this, there's a human element in all this. Somebody gets the funding, human being. The funder has very clear desires of what they want the outcome to be. The research is being conducted in your country because it actually can't be conducted in the country where the money is coming from, because one, it may be too expensive to conduct it. And the ethical requirements and considerations in that country are far more stringent than ours. Here you can get away with stuff, okay? So, the cost of doing what you are asking for is something that has been fought for the longest time. Include the cost of formative work. This thing we're discussing, before you even plan and write that, get to understand these people first. Get their input.
This is it.
When you've gotten their input, then write this document that you want. The opposite is what happens.
Yeah, and I think you have to have, I think one of the things that you have to also reconcile is the fact that when we have these smaller examples of community dialogue where communities are actually spearheading and saying no is no, this is not working, how we bring them to scale is one of the things where we kind of tend to fail. And we're trying to figure out, again, our recommendations don't provide like this, they don't have all the answers, right? But one of the things we say is that we think that they're catalytic in their nature, especially if they're adapted by different actors, depending on what they see as most useful for them. But I think that aspect of, not, and I don't say just community dialogue for just saying community dialogue. I'm talking about when you talk about, what exactly a primary healthcare system means for a community. It might be different in county A versus county B. And that's okay. That means that it's more effective for you to do it that way, because what do you want? You want people to have confidence in their healthcare system. You want them to even have that ownership of their healthcare system, to say, I have confidence in the primary healthcare facility or whatever healthcare facility is near me. And even if it's a public facility, it is actually doing what I need it to do.
Sure.
And that means that in that design, and that's why we strongly recommend for us to have that shift. Because if you do not have that shift where you look at the community as as the anchor, right? As the people-centered. When we say people-centered health systems, we're not talking about something that's nice to write in an academic paper.
Sure.
We're talking about how do you actualize that? And I think that's why we're saying, even after we provide these recommendations, how do we work or collaborate with countries? And by this, I don't just mean government. How do you collaborate with countries to say, we want to facilitate this? How do we make it actual? What does it mean for you? How do you want to engage with it? And that means not picking one recommendation, like, cherry picking the ones that are not only easiest, but also the ones that actually will make a longer term impact for the community, which is, again, at the heart of it, that's who you're trying to impact. That's who you're trying to make a difference for. Yeah.
I don't know whether it's a misconception or it's reality, that when people talk about universal health coverage, then there are those who interpret it to mean government provided health coverage and no space for private healthcare workers, health workers, or health providers to play. Is that the case? Or does UHC actually mean that private and public are working together collaboratively?
So it's the latter. It's what you said,
Okay.
right? So when you're looking at the role of private sector, and I keep emphasizing that this is everybody's business. So that means everyone has a role. And even though I mentioned earlier, one of the recommendations was around commodity security and defragmentation of healthcare markets. Even the private sector, as you look at it, you mentioned providers. Those are the people who work at the point of service. There are those people who work at the point of manufacturing, right?
Yeah.
There are also those people who work at different levels. They work at regulations. They work all these things. So one of the things that private sector does in terms of when you look at the African continent and you look at it kind of like a general way, the private sector is actually quite rich, right? If you look at different countries, I think here in Kenya, it's a really vibrant private sector that we have. And there's a lot of provision that is provided by private sector. When you look at points of service, this is not just faith-based, this is also for-profit healthcare facilities. And it's not just the bigger names, it's also the smaller rural facilities that are run, by a small business owner who are providing care. So how do you make sure that you make the environment is not just looking at it as the government from a regulatory perspective, where you just regulate, but you're looking at how do you integrate them into the system in a way that makes sense, right? So these are some of the dialogues that I know have been happening are around cost of care, because the cost of delivery of care in a private hospital is different from that in a public hospital. So as a government, the question is, how do you make the balance where you're able to provide care from if a private facility is the main facility in a geographical area, how do you make sure you include them? Because you can't say, no, you just have to go to the public facility, which is much further. So part of the conversation is to say, okay, how do we engage with this private sector, whichever way we are paying, this private player, whichever way we are paying them, whether it's through insurance, through direct tax, how do you integrate them into that process? So again, as you keep seeing me discuss things, I always shift back to the state actors, because I still think that as the holders of the institutions, as the people who guide, policy, who guide implementation, who guide the monitoring and evaluation, they still have a role to play. And that also includes creating that environment, whether it's making sure that there's an ease of business for people to do their work without harassment or, without fear or favor. They're able to deliver. That's one of the things that government needs to do, whether it's for manufacturers, service providers, and again, I really look at what happened during the initial phases of COVID-19 as that collaborative nature. We did it. We worked together. We brought things. We were getting no help from external people. But we work together internally, both private sector, public sector, civil society, where we were engaging with, we are making sure that we're working with communities to see how we can reduce the spread, to flatten the curve, both public and private sector, and also, again, with the anchor as communities.
You know why we ask this question?
Yeah.
If you look at the statistics we have on hospitals, how many public hospitals do we have in the country? No, I'm not seeking an answer. I'm simply saying, if you compare them with the private hospitals, you'll find we have more private hospitals than we have public hospitals.
Yeah.
So if you're talking about UHC, in fact, it's almost double in terms of numbers. So if you're talking about UHC, the private hospitals have to become a key partner in this whole thing. It's an unfortunate inversion, because the same seems to apply to the education sector. You talk education, you cannot talk education in this country without talking about the private sector.
Yeah.
So the discussion about who gets involved, they have to be involved.
No, I completely agree with you. And that's why it's I think if you look at the example again here in Kenya, you have as you said, you have such a vibrant healthcare sector, a private healthcare sector. So where you have private sector players, and as you talk about the numbers, actually those numbers are those smaller facilities, right? That are in the far-flung areas, and they're the ones who are actually providing care. Yeah. So how do you make sure that, one, is there a way for government to, if it's to make sure that this facility is able to deliver on their promise, how do you share some of those costs? How do you reduce the cost of doing business? How do you make sure that the country, the government can make smaller investments? So you continue with your regulatory role, but you continue to make those investments in a way that ensures you deliver care, reduces on your cost as a government to be able to deliver that care, and encourages, healthcare workers to deliver.
Yeah.
Because often the challenge as a healthcare worker, in my previous life, was you are in a situation where you have the skills and the knowledge to be able to deliver, but the infrastructure that is around you doesn't facilitate you to do so.
Doesn't support the work that you're doing.
Yes.
Dr. Walumbe, thank you very much for joining us. Dr. Rispah Walumbe is a health policy advisor with Amref Health Africa. We've been talking about the state of universal health coverage in Africa, and this is off the back of a report that was launched during the Conference on Public Health in Africa, held recently, and it's saying, well, there's very many steps that are being made towards attaining universal health coverage in Africa. Come again soon, Doc, so we can have more conversations like this.
If you'll have me, yeah, sure.
We will.
This is the Situation Room, the only way to start your day.